Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington. At the World Conference on Lung Cancer that was held in Toronto, Canada in late September, we saw the results of several important and potentially practice-changing trials, but among the most provocative of these was IMpower133 that arguably breaks the impasse in our treatment of extensive-stage small cell lung cancer. So I'd like to review what the trial was, what it showed, and what it might mean for practice going forward. Here is the schema for the IMpower133 trial. It enrolled just over 400 patients with previously untreated extensive-stage small cell lung cancer, and they were randomized 1-to-1 to a chemo backbone of carbo and etoposide for everybody with either placebo or atezolizumab every 3 weeks. Patients received up to 4 cycles with this combination, and if they hadn't progressed or developed prohibitive toxicity issues, they went on to a maintenance phase of either atezolizumab alone or placebo. And the co-primary endpoints of the trial were overall survival and investigator-assessed progression-free survival. Here is the overall survival as was featured in the New England Journal of Medicine publication by Leora Horn and colleagues that was published simultaneously with the presentation by Dr. Steve Liu at the Toronto meeting. And you can see that there is a statistically significant benefit in overall survival with a hazard ratio of 0.70. Now, the medians are not remarkably different. It's 2 months, and it goes from 10.3 months with chemo alone to 12.3 months with chemo and atezolizumab. The curves really only begin to separate meaningfully a little before the medians and become more pronounced over time. So the results are more impressive looking at a landmark such as 12-month overall survival, where you can see it is about 38% with placebo and nearly 52% with chemo and atezolizumab. So I would say that's a pretty meaningful difference. Now, we can also hope to separate out a group of patients more or less likely to benefit to see if that might be a strategy for the future. Here you could see the forest plot for the subgroup analysis, and there was not any obvious difference in these subgroups across clinical and demographic features. Now, you can look at the patients with brain metastases who didn't seem to have much of a benefit, but I'd be very cautious about using a post hoc subset analysis, particularly for a small group like this. I don't think that's meaningful or the appropriate way to use a post hoc subset analysis. I would say, though, that the most relevant findings are at the bottom, where I have the star, and we're looking at tumor mutational burden. This was actually a blood-based assay, and you can see that whether you used a cutoff of 10 or 16 mutations per megabase, there was no difference in the results suggesting that the benefit was greater with the patients with high TMB. Really here, across the board, the results were comparable, and all of these patients are getting a comparable benefit with the addition of atezolizumab to chemotherapy. Now let's turn to progression-free survival, and you can see that there is a statistically significant benefit. The hazard ratio is 0.77. Again, though, there is not a dramatic benefit at the medians. Median PFS is only about a month difference. The separation holds up over time, though, and so as you move toward the right side of these curves, there is a sustained separation favoring atezolizumab. When we look at a landmark such as 12-month PFS, there's a more than doubling, going from 5.4% at 1 year with the control arm to 12.6% with atezolizumab added to the chemotherapy. Now, looking at safety and tolerability, this really isn't something that I'm showing any information about, because the key points were that this is a chemo combination we have more than decades really of experience with, and we know what to expect with that. And we also know what to expect with atezolizumab or various other checkpoint inhibitors, and what we saw here was just a superimposition of those and no real surprises, no prohibitive toxicity issues. So I would not consider that to be a barrier to adoption at all. At the end of the day, I think the key question, of course, is whether this should be our new standard of care. Is it enough? Now, there are certainly detractors who say that it's only a 2-month difference in median overall survival. This wasn't wildly transformative, and I think that's fair to say, that though it is a positive trial, it's not the most screamingly different result, and it's not overwhelming. But this has been a setting where our gains have been quite hard to come by, and this is still, in my mind, a very clinically meaningful benefit. Not just that 2-month improvement, which is certainly something, but that there is a subgroup of patients who are getting more of a benefit. The curves separate more after the median, and I would say that particularly in the absence of any real toxicity issues, this is an approach that I am going to be inclined to favor for my patients. Now, I don't think that this is going to be our prevailing standard of care in 3 or 5 or 10 years. In fact, I am hopeful that different regimens, maybe immunotherapy combinations, and or a better strategy of selecting which patients are more or less likely to benefit could lead to future improvements from this. But at this time, I would say that we have at least broken past a very long-standing impasse of just giving a platinum and etoposide for most patients and never getting beyond that over the last 10 to 20 years. This is a meaningful benefit, and I hope that we move on from here. I welcome your thoughts, comments, questions, and I hope that you'll be inclined to like, comment, and subscribe to the channel. Thanks very much. We'll have more to talk about in future videos.